joining our 23rd virtual webinar. My name is Elmira Gurbanova. I am the coordinator of the Medical Consilium. I kindly ask you to turn your mics off to avoid some background noise. So thank you very much in advance. I would like to remind you that, as usual, we offer our webinar in two languages, English and Russian. You can choose the preferred language. In order to select the language, you need to press the symbol of the globe and choose the language you prefer. You can also choose the language of the slides in English or in Russian. On the top of the screen, you can select the preferred version. Our webinar materials can be downloaded. Today, after the main program, we will make one very important announcement, and therefore we kindly ask you to stay with us until the end of the webinar. Our webinar agenda today is going to be very intense, and we anticipate a lot of questions. So we kindly ask you to share your questions in the chat. And if we do not have enough time to review all your questions within an hour and a half of our webinar, we will answer your questions in writing and will forward the answers personally to those who asked them. So let us start the webinar. As you know, the webinars of our Virtual Medical Consilium are usually dedicated to the new WHO guidelines. We talk about some new things related to TB prevention and control, and the new guidelines have been issued not so long ago. And this is what we will be talking about today. Without any further ado, I would like to give the floor to Askar Yedilbayev from the WHO Euro. Thank you very much, dear Elmira. Dear colleagues, we are glad to welcome you at the 23rd webinar of the European Virtual Medical Consilium. Following the most recent guidelines, we decided to organize this discussion of the very important topic of infection control, which is very relevant for the WHO European region. Without taking too much time, we will start with the first presentation. I would like to thank the presenters and our interpreters who will help us communicate. And so let us start. And good luck. Thank you very much, Askar. I'm glad to present Dr. Avinash Kanchar from the Global TB Program headquarters, Geneva, who will give us an overview of the WHO guideline and handbook on TB prevention and control. Avinash, please, the floor is yours.
Thank you very much, and thank you, Elmira and colleagues, for the opportunity to present at the Consilium. I hope you see my screen well and you hear me well. So as Askar and Elmira mentioned, we recently had an publication of a document, an operational handbook on TB IPC, and I would try and my slides are not moving, so I'm trying to move them. Okay, so I will yeah. So in 2019 we actually published the guidelines on IPC, and you may all be aware it had 18 recommendations in total, including 7 which were specific for TB IPC, and there were some good practice statements as well. And this IPC guideline was structured into the administrative controls, environmental controls, respiratory protection, and it also mentioned the core components of general IPC, which I will describe a bit later. Infection prevention and control, as Askar mentioned, is critical to all WHO strategies for TB, and it's also part of the NTB strategy pillar 2, where it's given importance equivalent to the universal health coverage and as well as case notification. So it's an important element of all the work that we do. So I will give a bit of background. The WHO IPC policies since long focused largely on decreasing the risk of transmission in healthcare facilities. In 2009, for the first time, we had it expanded to cover more specific measures to applying to healthcare facilities, congregate settings, and households. 10 years after that, in 2019, it was considered important to look at the latest evidence and also the general IPC guidelines that were developed by a different department within WHO in 2016 that which provided a general and broader health systems framework. So what I'm going to focus on is this 2019 guideline, and following which we also developed an operational handbook this year. So as I mentioned, there are 7 recommendations. I'm sorry, the slides are moving on their own, so I need to go back and forth. There are 7 recommendations in total, 4 recommendations under the administrative control, 2 recommendations under the environmental controls, and then 1 on personal protection. So, I'm sorry, this is happening automatically and I don't know why. Okay, so the 4 recommendations under administrative control, they all aim to reduce transmission, TB transmission to healthcare workers and persons attending the healthcare facilities or other persons in settings with high risk of transmission. And the first of these recommendations is on triage of people with TB signs and symptoms or with TB disease. Recommendation 2 is on respiratory separation or isolation of people with presumed or demonstrated infectious TB. Recommendation 3 is prompt initiation of effective TB treatment of people with TB disease. And recommendation 4 is respiratory hygiene or cough etiquettes in people who have presumed or confirmed TB. So these are the 4 administrative control recommendations. As I said, 2 recommendations on environmental control. Recommendation 5 is on upper room germicidal ultraviolet systems, and recommendation 6 is using ventilation systems, including natural mixed mode or mechanical ventilation and recirculated air through HEPA filters. And we have 1 recommendation on use of particulate respirators within the framework of a respiratory protection program. And I will mention a bit about this as we move. As I also said, what formed the basis of this 2019 update was this document published in 2016 by WHO Department of Service Delivery and Safety, and it had 8 core components, which actually combined 11 recommendations and 3 good practice statements. And some of these recommendations are given specifically for use at the national level and facility level. But the aim is to address current as well as future threats and also to combat antimicrobial resistance. And we expect these guidelines to provide a basis for national IPC programs and protocols. So I will spend a minute to mention the 8 core components on this slide. These core components are IPC programs, IPC guidelines. If you can see the left side of the slide, education and training, healthcare associated infection surveillance, multimodal strategies, monitoring and audit and feedback, And also there is a recommendation around workload, staffing, bed occupancy, and infrastructure and materials. So as you can see, this is general health system wide approaches that provides a backbone for TB IPC as well. And as I said, some of the recommendations are specific for the healthcare facility level as well as at the national level. And in the operational handbook that we developed, that we published this year, we have tried to suggest ways in which TB IPC could be integrated across all of these IPC elements. So this is the document I mentioned, which was published this year, an operational handbook, and this is in series of the documents that WHO has recently been publishing along with all the guidelines. And these operational handbooks aim to provide practical advice and share best practices, checklists, and other job aids. And it targets largely the policymakers at the national and subnational level, program managers, and managers at the facility levels, occupational health officials, and also the frontline health workers. So in the rest of my presentation, I would try and provide a glimpse into what this operational handbook contains and how you can benefit from it in your national planning and implementation. So as I said, the focus is to implement all the 7 recommendations as a package of care and not as individual recommendation in silo. So all the administrative controls, environmental controls, as well as respiratory protection should be implemented as a package of intervention. And within the operational handbook, we provide guidance on each of the element at granular level, and we suggest elements that programs need to consider in developing the plans. For example, we have a detailed section mentioning how to coordinate and implement TB IPC and what should go into the planning. So we provide suggestions on national as well as subnational level IPC focal person and their roles and responsibilities, including development of the IPC plans, development of norms and regulations, mobilizing funds and resources from governments or donors, and also developing content for the education and advocacy. This applies both at the subnational level, if you have, and health facility level. And then there needs to be an IPC committee as recommended by the in 2016. But TB IPC should also be prioritized within any existing infection control committees at the health facility level. And at the health facility level, these committees should develop practical implementation plans for the health facility. These committees should advise the authorities on the equipments such as respirators or the UGV equipment that would be appropriate for the health facility. The operational handbook also has a section that provides tools to undertake facility risk assessment if that is not already done or that needs to be done at a regular interval. And this risk assessment should include review of the patient flow within the facility, location of the TB services, areas where people congregate, such as the waiting areas, and status of the implementation of the existing equipment. If there are ventilation systems, how well are these systems functioning? And this is an outline for a IPC plan, and it provides many more details. I just provided a snapshot here. And the handbook also covers some tools like this, for example, on triage and separation. So this comes from a facility in Ghana, where an individual is identified. Uh, a dedicated person identifies people who have cough within the health facility, and if they have cough more than 2 weeks, they get education on cough etiquettes, and then they are fast tracked for investigation or further management. And if they don't have cough for 2 weeks, then they they remain in the normal queue. So these are the sort of illustrative examples that you will find in the operational handbook. And as I said, we provide suggestions on how TB IPC can be integrated into the larger infection prevention committees and programs within the countries. So we have suggestions across all the 8 components, and I will just elicit a few of them. The core component 1 and 2 are on IPC programs and guidelines, and what we suggest is TB IPC should be part of the mandate of the existing IPC committee, and a TB focal person should be part of the IPC committees at the health facility level as well. Also, when national guidelines are developed, TB IPC should be reflected into that. The implementation protocols or standard operating procedures for IPC should have dedicated space for TB as well. Component 3 and 4 relate to education trainings and surveillance, and I've mentioned about the education. For surveillance bit, we suggest to focus on few indicators, and the most important probably is TB among healthcare workers, which can act as a proxy indicator for TB IPC actions, and this could be used for surveillance of the way programs are being implemented. We also suggest systematic and periodic screening of healthcare workers, including using chest X-rays and also prompt start of TB treatment. The next set of components cover strategies for implementation, and as I said, we suggest multimodal strategies, comprehensive strategies instead of standalone interventions for IPC, and monitoring key variables both at the national level and local level, and also providing feedback to the staff are also important. And the final set of core components are on workload, staffing, bed occupancy, and infrastructure. And you are all aware, we encourage ambulatory care versus home-based care. Ambulatory or home-based care versus inpatient care. We recommend limitation on hospital admission to only those with severe disease or need for admission, like severe adverse events. And there are recommendations around staffing, sufficient staffing vis-a-vis the patient load in the health facilities. So in the operational handbook, as I said, there we provide suggestions which are very granular. For example, on trainings and what to cover in the trainings. So this is an example for the training content for triage and what needs to be covered when healthcare workers are trained on this. So we need to explain why triage, what are the principles, what are the key steps, and then also educate them on personal protection, on appropriate use of respirators, and avoiding contamination or use of contaminated medical masks and respirators. So this is the sort of information you can expect from the operational handbook. So it's quite detailed, and it's quite hands-on. So around environmental control, we go in great depth on ultraviolet, germicidal ultraviolet systems. We provide a lot of background and technical details on what is ultraviolet light, which of these is uh, what is the range of the wavelength where it's more effective, as you can see from this slide, the wavelength between 260 to 280 nanometers is bactericidal, or it inactivates airborne pathogens, and we emphasize that such GUV systems should be installed as a package of IPC intervention, and very strong administrative controls as well as respiratory protection measures should be in place before we prioritize the use of GUV systems. And then we also provide examples of how different types of these systems based on the height of the room or the size of the room. So in the handbook, you'll find uh, uh, description on the factors that influence effectiveness of GUV fixtures, and the suitability of the rooms and the number of fixtures that may be required for a particular room size, and also the cost consideration. Also to point out, GUV systems really depend on the effective air mixing. So we need investments to ensure that proper air mixing happens and the GU systems are exposed to the contaminated air well. So for these systems, we suggest adequate amount of resources to be allocated both for installation as well as routine maintenance, without which this system may not function well and may provide false sense of security and actually be harmful. For ventilation systems, we put a lot of emphasis on the principles, which is need to remove the stale air and infuse fresh air to reduce the concentration of the infectious agents. And we provide examples on how many what would be the requirement or what would be a good ventilation system. So this is an example where it shows like 12 air changes per hour would probably be optimal in most situations, and any ventilation system that we have should aim to achieve at least these many number of air changes in an hour for effective infection control. So we also provide comparative advantages and disadvantages of mechanical versus natural ventilation. You'd agree the mechanical ventilation systems are, although they suit well in all climates and they would be more comfortable for the occupants, but the disadvantage is installation and the cost of installation, maintenance. So against which the natural ventilation, although it suits in most of the warm and temperate climates, it may not suit in very cold winters. Uh, and but the advantage is it's less expensive and it will require less of maintenance. And in hybrid systems, it would probably be best option in most of the situations. So you can find more details. You can also find details on like this is an example uh, where we suggest appropriate seating arrangements within the health facility, or appropriate location of the beds within the health facility, vis-a-vis the source of the uh, supply of the air and exhaust and the position of the exhaust, whether be it windows or mechanical systems. So we provide, I mean, you can see on this slide the correct ways of seating, and keeping in mind that the patient should always be nearest to the exhaust, and the provider should be near the uh, inflow or the pure air or cleaner air. So you can find illustrative examples like this in the handbook. Uh, So for as I said, we for the respiratory protection or personal protection, we advise a comprehensive program. The TB-IPC focal persons in a health facility should be responsible uh, to ensure availability uh, of the equipments and tools, having the standard operating procedures, having enough resources to ensure that the masks and the respirators are available to the staff regularly. We need to have more options of the size of the respirators as well. Uh, and then we need a mechanism to ensure that the masks or the respirators fit well to the users. So we need a fit testing program and training on checking if the mask is safe. So we in the handbook you can find more details on the different types of respirators available. The N95s, we have now all grown familiar with all the respirators and masks during the pandemic, and you'll find more details within the handbook, including for the medical masks, and that they are best suited for the infectious TB patients rather than the healthcare workers, and and uh, and also you'll find some details on the fit testing programs that we need wherever respirators are being provided. So this is an example of a kit and the way the fit testing is performed, and then we provide steps to do a seal check before every use of a respirator. So these are the simple steps that need to be implemented, or all the healthcare workers needs to be trained upon. The handbook also provides key indicators for recording and reporting and routine monitoring as well. So these are the top 5 that we suggest. The first one being having an IPC plan in the health facility, which is valid and updated. Having TB IPC focal persons with dedicated time, and then variables or data from the surveillance records, like time from diagnosis to start of TB treatment, and which is one of the key elements of infection control within the health facility. Uh, and and also regards supplies, we recommend use of availability of respirators for the healthcare workers as one of the key indicators, uh, and 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 uh, and for surveillance purpose, uh, we recommend use of this indicator, indicator 5, which is relative risk of TB among healthcare workers compared to the general population. And some of these data would be routinely captured within the health facility, but may not be reported regularly. So you may need to establish uh, survey, undertake separate surveys or separate ways of capturing this information. And within the handbook, you will find different annexes with more details. Like we have an annex dedicated to data elements that can be used for monitoring implementation of TB-IPC. There is a tool that can be used for risk assessment, a checklist for program reviews, uh, and tools that can be used by healthcare workers for regular TB screening or recording of the TB screening activities. And then there are several others which are like sample tools for to develop health education material. So you can adopt these to your settings. And there are also technical annexes which cover in great depth about ultraviolet light fixtures and choosing radiometers to measure the ultraviolet C irradiations. And then there is an example from a country where they developed simple messages for the healthcare workers. So this is in a nutshell about the operational handbook that we published this year, which is based on the guidelines from 2019. And you can find these guidelines as well as all the WHO guidelines as well as operational handbooks on this digital platform that we call knowledge sharing platform. And in this on this platform you can see there is a tab on recommendations where you can find details of the evidence that was reviewed by the guideline groups when the recommendations were made, and Grigory would cover some of these evidences in the next presentation. So I would stop here and acknowledge my colleagues in the WHO headquarters as well as the regional and country offices and all the others on the slide. Thank you very much for the time and patient listening.
Большое спасибо, Авинаш, за такой прекрасный обзор практического справочника по инфекционным.
Thank you, Avinash, for such a great overview. Dear participants, I would like to remind you that you have an option of asking questions. Leave your questions in the chat. We will either voice them during the webinar or provide you a written response. At this, please let me pass the mic to Dr. Grigory Volchenkov to cover the evidence lying behind the WHO recommendations on TB infection prevention and control. I would like to remind you that Dr. Volchenkov is a WHO expert in this particular thematic area. Grigory, the floor is yours. Thank you very much, Elmira. Good day, dear colleagues. Good evening, dear colleagues. I'm grateful, first and foremost, for this opportunity to speak on this important for the WHO European region topic. Unfortunately, we have a high prevalence of drug-resistant TB, in part due to ignoring the infectious nature of this disease, and which resulted in a generation of drug-resistant forms of TB within the TB services in healthcare facilities, because our measures on prevention of the infections were quite often ineffective. Our task is not to repeat the mistakes and to make our work safe for ourselves, for personnel, and for the visitors. Therefore, I hope that you see my slides. Yes, we see. Avinash presented the overview of the documents published recently and those existing for quite a few years. I would very briefly repeat the fact that there are lots of documents. The most recent one, WHO Operational Handbook, a very detailed guide published on the 1st of September, and Avinash presented the review of that document. That's a very detailed document on how to implement the previously published recommendations. But historically, the first documents were published in the end of 90s, in 2009. The next one was published, but the most recent one on TB prevention, TB infection prevention and control was published in 2019. And it used great approach, using evidence-based data to prepare the recommendations. In 2022, a year ago, the document of 2019 was a bit reformed, just a new design of the same document of 2019. And in September, this detailed operational handbook was released with practical recommendations on how to implement in practice all the previously published recommendations, with lots of examples on organizational measures, on posters, on how to actually put into practice the recommendations. A few words about the preparation of this evidence-based guide of 2019, which was reformatted in 2022. Great approach was used. That's a system for the grading of recommendations, assessment, development, and evaluation approach. And the whole process was performed with the participation of the World Health Organization. Fuad Mirzaev was the coordinator. And the key expert on grade approach was also involved at the final stage, the finalization of the recommendation. I was part of the guidelines development group, and this grade approach helped to assess the quality of evidence based to rate the certainty of evidence based on the PICO approach or PICO questions. All the recommendations were graded as high, moderate, low, or very low based on a set of criteria. And the criteria included the quality of the study design, the risk of bias in the study data, inconsistency of data, imprecision, indirectness of certain indicators, and also publication bias. So the quality of evidence was taken into consideration when drafting the recommendations. And also the strength of recommendations expresses the opinion of the experts, or expresses the conference whether the desirable effects of the recommendations outweigh the undesirable effects. For example, in various clinical trials, we use also approach. And also, the same approach was used to assess the infection control measures. And also, the guideline development process took into consideration resource use and cost of various interventions, and also the needs of public health. If you want to learn more about the grade approach, you can use the link you see on the slide. So how was the document prepared? First, we developed the priority questions within the guidelines development group. We then performed data collection. We assessed the scientific journals. Several thousand publications were identified. We also assessed the quality of data. We also synthesized the evidence, and based on all the results, we formulated the recommendations. And the final stage was planning for the dissemination of the recommendations and their implementation. And that was covered by the publication of last year of the operational handbook. So what is a PICO question? It stands for population, intervention, control, or comparator, and outcome. So each question is separated into 4 key components to facilitate the identification of relevant information for the recommendation. For example, a PICO question on respiratory protection. In health workers and persons in healthcare or other settings with a high risk of TB transmission, do the following interventions: use of particulate respirators and implementation of a respiratory protection program, when compared with no intervention, reduce risk of TB transmission. So here we can find the key group, population. Those are health workers or people who are present at settings with high risk of TB transmission. So this is the population on whom we follow the effect of the intervention. The intervention in this particular question is the use of particulate respirators within the respiratory protection program. The control in this particular question will be no intervention, will be absence of any interventions. So in our case, there's no interventions, means no use of a particular respirator. And the outcome will be the impact on risk of TB transmission in this particular population. So all the questions reviewed by the guideline development group, undergone the same process. When we searched for the evidence for particular recommendation. I will present a very brief overview of all 7 recommendations. They are multi-layered, they are not quite simple, and I will tell you about the evidence lying behind the recommendations which were included into the document of 2019. The first 4 recommendations, as Avinash has already said, are dedicated to administrative or organizational methods of infection control. The first is triage, or separation of flows based on certain signs. Triage of people with TB signs and symptoms or with TB disease is recommended to reduce tuberculosis transmission to health workers, persons attending healthcare facilities, or other person in settings with a high risk of transmission. So this is a conditional recommendation based on very low certainty of the estimates of effects. We will come back to the meaning of conditional recommendation and what is low certainty of the estimates of effect. And the evidence base, here you see the list of the most prominent studies. Here you have 9. There are more of them, but here are the most prominent, the most important ones. So the cumulative effect of the published data. So we analyzed the effect on the population of healthcare workers, and the indicator was the conversion of tuberculin skin tests or latent TB infection. And it was proven that absolute risk reduction was about 6%. So the absolute risk reduction of 6% for LTBI incidence among healthcare workers if adequate triage was used to separate patients with signs of active TB or with the confirmed TB. If we take visitors of healthcare facilities, then this risk will reduce by 12.6%. You see that the risk reduced by 12.6% if triage was used compared to settings with no triage implemented. So it's not absolute, it's not relative risk reduction, but rather it's absolute risk reduction. Recommendation number 2, it's respiratory separation or isolation. Respiratory isolation is described in great detail in the latest guidelines. Not physical isolation, it's isolation which would prevent spread of infectious aerosols between various zones and risk zones. And the recommendation runs as follows. To reduce the risk of TB transmission among healthcare workers or other persons attending, it's recommended to use respiratory separation or isolation of people with presumed or demonstrated infectious TB. So what is the evidence-based? The data are numerous and they go back as 30 years into the history, and based on the analysis of all the published data, it was confirmed that absolute risk reduction was about 2% in the settings with proper respiratory separation or isolation. We can say that respiratory isolation is a new term. It was put into practice after the pandemic. And I'm not sure whether we were using proper respiratory isolation in, for example, in 90s. But according to published data, we see that absolute risk reduction was 2% in healthcare workers. Another important, for us in particular, measures with a huge breakthrough in its implementation. It's prompt initiation or of effective treatment. Effective treatment is the treatment which is based on the results of rapid DST tests right after the results are received in order to reduce the risk of TB infectious spread among healthcare workers or other persons attending healthcare settings. It's important to promptly initiate effective treatment of people with TB disease. Here, we see that a retrospective cohort study in New York Hospital, these are the data of 1995, pretty old data. They observed a reduction in the incidence of active TB by 6.2% compared to and the population they studied were HIV positive individuals admitted to the ward. So absolute risk reduction was 6.2 and the incidence dropped from 8.8% to 2.6%. So a very significant, pronounced risk reduction with prompt, effective treatment initiation right after the DST results were available. It's important topic, but I can tell you that a breakthrough publication of 70s was the publication on Indian data, which showed that in close household contacts, no infections happened when proper treatment was started of the positive patients, and evidence showed that smear and culture positive patients do not infect close contacts, and sputum smear and culture positivity correlated with transmission before but not on therapy. So prior to drug-resistant TB, the researchers show that less than 2 weeks were necessary for the patients to stop shedding mycobacteria. Even in households, patients stopped infecting even close contacts. The data were really important, and the experiments were repeated in the era of drug-resistant TB. And I would like to remind you of this classic study of Dr. Riley and Wells, which was performed in the United States in Baltimore, where they built an experimental ward, a TB ward, that was also done in the era prior to the emergence of drug-resistant TB. They admitted patients with positive smear result, and they also exposed guinea pigs to the air from the patient's ward. And guinea pigs were also susceptible to TB. And the researchers show that on proper chemotherapy, at that time only first-line drugs were available, limited number of drugs were available, but nevertheless, on effective treatment, patients stopped shedding the infection. And similar design study was performed has been performed recently. It was repeated 10 years ago in Southern Africa, where they built an experimental facility for patients with drug-resistant TB with a properly built ventilation system, which provided exhausted air to the cages with guinea pigs, in whom they also used tuberculin skin test to assess the conversion. They admitted only the patients with rifampicin, with MDR TB, and they would start treatment. They would put patients on treatment based on their DST results. And almost on day 2 or 3, conversions of tuberculin skin tests stopped. At that time, they had no rapid tests, with the only exception of patients who had resistance to fluoroquinolones, or ERI-TB. Only those patients, they continued to shed infection, and guinea pigs continued to be infected. That once again proved the aerial way of transmission, and also it confirmed the rapid effect of chemotherapy, especially if chemotherapy was based on the results of a rapid DST. Respiratory hygiene, another administrative measure, even though it includes wearing surgical masks. It runs as follows: respiratory hygiene, including cough etiquette in people with presumed or confirmed TB, is recommended to reduce tuberculosis transmission to health workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission. Surgical masks wearing or cloth masks wearing is included, not only the cough etiquette or cough hygiene. Speaking about evidence, it was also received in the South African research with the engagement of our colleagues from the Harvard University. And the researchers showed that using a mask by the patients reduced the risk of further spread of infection. So the number of infected guinea pigs dropped just because of the patients in the ward was wearing mask and follow the requirements of respiratory hygiene. So this is the most perhaps outstanding evidence of the recommendation. Even though I would like to say that studies with laboratory animals are considered indirect with low quality. Even that is why we have low strength of the recommendations. Environmental controls, use of upper room germicidal ultraviolet systems, not simply germicidal ultraviolet systems, but those that irradiate upper parts of the room, creating a safe environment in the lower habitated areas of the room. Use of such systems irradiating the upper parts of the rooms is recommended to reduce tuberculosis transmissions to health workers, persons attending healthcare facilities, and other people in high-risk zones. This is also a conditional recommendation based on moderate certainty of the estimates of effect. We come back to the experiments performed in South Africa, where they used germicidal ultraviolet systems as the only interventions, and they observed the reduction of risk by 72.4%. So if patients' wards were equipped with such a germicidal ultraviolet irradiator, the number of positive or the number of conversions in guinea pigs dropped. Another study was performed in the Great Britain, where they also created an experimental hospital where they supplied exhausted air from the wards to the cages of guinea pigs, and also analyzed the conversion of TSTs. And you see that the same results are observed. So the quality of data was very high, and therefore the quality of the recommendation is high. Mechanical recirculation ventilation systems are part of recommendation 6, and this recommendation pertains to the use of ventilation systems, various modes of ventilation. But only one remark is made, that the use of portable room air cleaners is not advised as a system to reduce the tuberculosis transmissions to health workers, persons attending healthcare facilities, or other people in settings with high risk of transmission, because there are data saying that the majority of such appliances are not quite effective to ensure proper protection. But there are a lot of evidence pieces from long ago and more recent ones. So if we assess the cumulative effect, we will see that when using various types of ventilations, the risk of further spread of infection reduced by 51.5%. So it means that there is no one single measure there is no silver bullet which would drop your risk by 100%. Therefore, we speak about a hierarchy of measures or a whole arsenal of measures which should be applied altogether. And one more recommendation I would like to touch upon is the use of respiratory protection. On one more slide, comparing various types of mechanical ventilation. Avinash has already touched upon this comparison, but here we can assess the balance of effects, whether positive effects prevail over negative ones. We have also assessed the amount of resources required, cost effectiveness, issues of equity, acceptability, and also feasibility of various modes of mechanical ventilation. And not only mechanical, but other types of ventilation. Recirculation is not recommended in low resource settings because the weakest point is the quality of maintenance and design of recirculation system, which might result in improper functioning of those systems due to poor design, which all results in backflow of infected air into the room. Therefore, ventilation should take into account the climate and also the structural designs of the premises. And the final recommendation on respiratory protections, which runs as follows: particular respirators within the framework of a respiratory protection program are recommended to reduce tuberculosis transmission to health workers, persons attending healthcare facilities, or other persons in settings with a high risk of transmission. You see a huge number of publications, and based on the published data, integral effect is 72.4 reduction in the risk, almost threefold reduction. I would like to draw attention to the publication of Fella on New York and other researches. You can read about the results of the projects. And this is part of various IPC guidelines. And by the way, the COVID-19 pandemic served as an impetus and drew additional attention to infection prevention control measures, because all the recommendations, they aim to reduce the risk of aerosol transmission of infection. So that was very brief. That is a brief review of all the 7 recommendations based on grade recommendations when analyzing the evidence data. No one doubts that ventilation is of importance, but we took into account all the available data. We see that the majority of recommendations are conditional, so they have conditional strength, and 2 are strong recommendations. Only 2 recommendations, the one on prompt initiation of effective TB treatment and respiratory hygiene, are strong recommendations, with no doubt that negative effect of the listed interventions can outweigh the positive effect. And certainty of evidence, the highest certainty of evidence belongs to the use of upper room GUV systems. very low certainty in the estimates of effect does not mean that it's a poor recommendation. Why do we have poor quality of the data used when developing the guidelines of 2019 and 2022? First and foremost, we have limited number of published data items on various TB infection control. And that topic perhaps used to be of low priority to the majority of programs. And infection control activities are in a majority of cases used as a set of activities, not in isolation. For example, we cannot just stop using respirators to assess, for example, the effect. No ethical committee will approve your approach to the study. So therefore, it's very difficult to assess the impact of a particular measure on overall risk reduction. And another thing, studies on animals, on guinea pigs, were perceived as indirect, which reduced the quality within the grade approach. They were taken into account, but because those were the studies performed on animals, the quality, the certainty was lower. And published data are quite varying. Data are not the same. I would like to refer you to the documents published at the website of the working group of the Stop TB partnership, where we have information materials in Russian, Spain, English, Italian, and even Chinese. Various applied issues are well described, and we describe proper implementation of the recommendations you've learned about today. On the 14th of November in France, there will be a special meeting on all these measures. You will be able to discuss them, and you'll be able to try using the instruments available to us right now.
Thank you very much, Grigory, for such an interesting and very clear overview of the studies that lay the foundation for the WHO recommendations with due consideration of some weaknesses and strengths. I would like to ask you and Avinash to follow the questions in our chat. I'm sure that our participants ask very interesting questions. And we continue with our agenda, and I would like to give the floor to the regional advisor on TB and mDR-TB in the WHO Euro, Askar Yedilbayev. He will tell us about the people-centered approach. Thank you very much, Elmira. Do you see my slides? Yes, I can see your slides. Good, thank you very much, dear colleagues. In the conclusion of our webinar, I would like to say that in the WHO Euro, or in the European region of the WHO, patient-centered approach is highlighted in the regional plan that was adopted by all member states at the regional committee for Europe in September of 2022. I would like to say that people-centered approach is relevant to all technical directions of TB control. It covers the issues of prevention of tuberculosis, preventive screening, diagnosis, treatment, and TB care. So in all these areas, we use people-centered approach. And in all the activities that are recommended by the World Health Organization, we should have people-centered approach. And speaking of some regulatory documents in our region, uh, we say that service delivery should be ensured in good collaboration with the primary health care, with the public health facilities, in good collaboration with the civil society organizations and other stakeholders in order to ensure good coverage with healthcare. Implementation of activities aimed at strengthening approaches that are people-centered have been implemented since quite long ago. And in our work, we use the existing recommendations and guidelines that existed. And the main recommendations included decentralization of ambulatory care. There were some recommendations related to improving the adherence to treatment, provision of financial, psychological support, training of the staff, and as Grigory Volchenkov has mentioned in his presentation, the COVID-19 pandemic pushed us closer towards the outpatient care, ambulatory care, and home-based care with video-supported treatment. Down below, you can see the most recent WHO guidelines focused on active engagement of the civil society organizations that provide support in active TB control. I believe that it is time to update these recommendations because now we have an updated version of the WHO guidelines where the engagement of civil society organizations and other stakeholders play a very important role in provision of people-centered care. In the WHO region, tuberculosis with drug resistance and multi-drug resistance is a challenge. And a lot of countries with high burden of mDR-TB are located in our region. And of course, we need to ensure good TB care, which can better be provided at the level of the communities. However, many countries with high burden of TB and high burden of drug-resistant tuberculosis still offer a wide range of inpatient services to patients with drug-susceptible and drug-resistant tuberculosis. And there are reasons for that. We have some historical approaches to staffing and payments for services. They stimulate hospitalization of patients without very clear indications and hospitalization for a long time. And as I said, that this kind of approaches are closely related to the models of healthcare and models of healthcare financing. Due to the lack of resources and sometimes due to the lack of the potential, primary healthcare services are not always well prepared for adequate TB treatment and treatment of drug-resistant forms of tuberculosis. The main reasons or the main obstacles for expansion of TB care could be the lack of new models, including new models of financing of tuberculosis and new models of staffing and provision of social support to TB patients. Many countries in our region try to focus on decreasing hospitalization, and we can review the results of 11 a review of the project that was implemented in 11 countries, and that project was focused on a decrease of unnecessary hospitalizations. And you can see the list of the countries on this slide. Among new TB cases, the number of hospitalizations went down significantly, and the average duration of hospitalization of all cases of tuberculosis went down from 73 to 53% in 11 countries of the project. As for the drug-resistant tuberculosis, the hospitalization of all cases of drug-resistant tuberculosis was and is high, and we don't see major changes over time with that. Over 80% of patients with drug-resistant tuberculosis in those 11 countries were subject to hospitalization, and the average duration of hospitalizations of patients with drug-resistant tuberculosis went down from 158 to 95 days from 2015 to 2020. But if we look at this data in more details, we can see the situation of 2015 in red and in blue, the numbers of 2020. And I would like to say that the duration of hospitalization of patients with drug-susceptible tuberculosis has changed significantly. A lot of work has been done in the countries, and we could see good understanding of the new approaches at the level of healthcare management and national TB program management. And this is what Grigory Vasilyevich Volchenkov mentioned in his program. Uh, this new approach was supported, and we see that the work is in progress. I would like to say that Dr. Volchenkov has shared lots of evidence-based data in his presentation, and we see that the immediate start of treatment based on the DST results can effect on cessation of the spread of infection. As Dr. Volchenkov has showed in his presentation, there are lots of studies that focused on the effect of treatment on transmission of infection. And we know about the study performed in India, review of 1976. And I would like to say that the conclusion of this review showed that the effect of chemotherapy was seen in twofold or threefold increase of success in reduction of infectivity of patients. So that was a review of 1976, and we can say that even almost 50 years ago, people were talking about this problem. Now we have more recent data, and the previous speaker highlighted that. And now we can say once again that early start of treatment can reduce the spread of nosocomial infection. And we can say that the effectiveness of TB treatment can be very high and very effective for reduction of the spread of infection. WHO guidelines were issued in 2022, and they can help us use safer treatment regimens and to decrease the duration of chemotherapy. We also have updated guidelines for treatment of drug-resistant tuberculosis issued in December of 2022. And it showed that the duration of drug-susceptible and drug-resistant tuberculosis can be the same 6 months with the use of fully oral treatment regimens. So now we can see that we can effectively treat patients using shorter treatment regimens in the outpatient settings. And this is the example of people-centered approach. We need to use various tools and approaches such as treatment support approach.
And also, proper treatment adherence can also improve the conversion. And now when we can treat patients with shorter treatment regimens, with more reliable results of drug sensitivity and susceptibility. And we can be sure that people we treat are susceptible because we use drugs not quite often used in the past. And we can make the treatment comfortable for the patients and for the healthcare provider. What patients need to be admitted and what patients need respiratory isolation because they shed the bacilli. Patients who shed bacilli, who are contagious, can be treated at home, and the treatment performed at home will be effective. We have more and more data on cost effectiveness, on efficiency of the use of decentralized outpatient programs for the treatment of not only drug susceptible TB patients, but also patients with drug-resistant TB. I would like also mention the fact, and Avinash has mentioned it, treatment at the outpatient stage reveals the same or even higher efficacy rates compared to mixed or fully inpatient treatment. What are the criteria for hospitalization? Perhaps that's a topic for a separate webinar, which should pertain to complications of TB. Of course, those patients admitted perhaps have severe forms of TB needing surgical treatment or bleedings. We will cover all those aspects in the nearest future. And as the final conclusion, I would like to give an example of one of the documents recommendations. It's an addition to Module 4 of the consolidated guidelines, and it deals with tuberculosis care and support for patients both with drug-susceptible and drug-resistant TB. There are two types of recommendations. The first set of recommendations, which describe the set of activities on care and support, and the second set describing the methods that can be used. And I would like to mention that there are recommendations of various strength and certainty of evidence, but all patients on TB treatment should be educated and also should be provided consultations on TB treatment, and we should try using the methods which will help patients to be compliant, which will improve treatment adherence. And TB patients might be offered the following types of treatment continuations. Support, treatment support at the community level or at home is more preferable compared to treatment support at the facility. And this is the recommendation which flows from our discussion today, from our webinar. And I would like to draw attention to recommendation B on the use of comfortable methods for both healthcare providers and for patients and for the family members, which will also reduce the stigma associated with TB, and video-supported treatment, which can replace in-person approaches, and it can be organized and properly implemented by healthcare providers and patients. This is the approach widely used during the pandemic, and I would like to draw attention to the term video-supported treatment. That's the term introduced by the WHO Europe in 2020 when we published our guide on the video-supported treatment. And the final thing is about the models of care for people with the focus, people with multidrug-resistant TB with a focus on outpatient treatment. Even though it's a conditional recommendation, it is based on the proper amount of evidence pieces. And patients with mDR-TB and treated for mDR-TB should be provided a decentralized model of care. In our region, in the European region, there are many models when outpatient phase of treatment is replaced, the inpatient phase of treatment is replaced with outpatient treatment, either through video-supported treatment or through home visits when a team of nurses and other specialists visit patients at their place of residence. Here you see the data. By the end of 2021, during the pandemic of COVID-19, we saw varying the rate of the use of video-supported treatment, and it varied from low to almost 60% coverage. We hope that if we take data by 2023, the numbers will increase. So we should use people-centered approaches, which will help not only the patients themselves, but will facilitate the work of healthcare systems. And we expect good results. We expect bold results, bold initiatives to be implemented, and we want to see the results in the reduction of incidents of susceptible and resistant TB cases, and that can be done only through partnership with various stakeholders and communities, and our joint work can accelerate the work so you can do it in your countries. Thank you very much, Askar. It's a very good conclusion for our webinar. That's a very good conclusion of all the work. We all strive to ensure and to provide people-centered services, including in the area of TB infection prevention and control. We have 5 minutes till the end. I don't see any hands raised. From my part, I would like to thank everyone who left a question in the chat. I see that all the questions have been already answered, and perhaps we can use the last minutes left to give the floor to our panelists, to Avinash and to Grigory, to repeat the key take-home messages they would like to pass to the audience, and maybe underline anything from the chat. Avinash, perhaps you should go first. The first question about the frequency of screening of healthcare workers, and then Grigory, who might repeat once again the things about outpatient care, regardless of the smear microscopy result. Avinash, please go first.
Thank you. So what I can say is we need a respiratory or the personal protection program at the health facility levels, and screening of healthcare workers should be part of that. So what I mean is healthcare workers should have access to respirators, They should have access to fit testing, so they have an appropriate personal protection. But at the same time, they should at least receive TB screening once in a year. So it should be TB symptom screening plus a chest X-ray, and if they need, they should get rapid diagnostics for TB as well, and test for TB infection if they are available. So at least once chest X-ray, but after that screening, if a healthcare worker develops more symptoms, then maybe you need to repeat. But for all the healthcare workers who are involved in care for TB patients, we suggest at least once in a year they should get the screen. Thank you.
Спасибо большое. И Григорий,
Thank you very much. Grigory, please. Briefly about outpatient treatment. There was a very important question from Mikhaila. In addition to clinical indications, if smear is positive, is it a must for a person to be admitted? I would like to emphasize that it's not the bed that treats, but prompt initiation of treatment. The earlier we start treatment, the lower the risk. There are, of course, certain indications. If it's a severe case, if it's a need to observe the patients 24/7 until stabilization of the condition. But if we can start treatment today at home under the control with the tests available now, it's better to do it earlier and sooner at home than perhaps respiratory isolation for a brief period of time, 2-3 days, maybe a bit longer if it's a drug-resistant case. So it means that we can perform treatment from the start at home. Smear positivity is the criteria for being infectious, because if a patient is not treated, a patient on treatment, for such a patient, smear positivity wouldn't be the criteria of infectiousness. If we have DST's results and if we put the patients on the properly selected drugs, then the risk is significantly reduced. Thank you, Grigory. Dear colleagues, I have promised you that at the end we will make a very important brief announcement. Alex, please, the floor is yours. Thank you, Elmira. Thank you, dear colleagues. It's been 3 years since the start of the work of our Virtual Medical Consilium. The first webinar was in September, and the first cases were reviewed 3 years ago in October. And therefore, for the anniversary, together with PAS Moldova, we created a website for the Virtual Medical Consilium. It's available in 2 languages, in English and in Russian. We will share the link with all of you. You can select question, but what is the purpose of this website? First, it contains general information about the Consilium. It also has the archive of all the webinars since 2020. You can first watch online the webinars. You can download the slide decks presented during the webinars. Many webinars are available in both languages, English and Russian. Some delivered at the very beginning were recorded only in the original audio. There are also video instructions on vision acuity check and on other procedures. We will make announcements on the upcoming webinars or other news pertaining to the work of a Virtual Consilium. You can also find instructions on how to present a case. Instructions are available in both languages. You can also download the case presenting form and send requests. In future, we want to make it possible to present cases through this platform, through this website. If you experience any difficulties or glitches, please let us know. It will help us to improve this website and make it more useful. Thank you, Alex. From my side, I would like to say that we will share the link to the platform and we will share the materials. I would like to thank everyone, first and foremost, our panelists for such a detailed and interesting overview of this important topic, for participation in the discussion. I would like to thank all the participants. I'm looking forward to our next meetings during the webinars. I wish you very good end of week. All the best.
Thank you.
Спасибо, до свидания.